questions on NCLEX. Typically, if you're going to get reproductive, things are going to be more maternity related, and we're going to cover the whole maternity section. The things that you might get for reproductive are going to be related to BPH and maybe some medications for BPH, and then PSA level. There's another level here we'll talk about. Some of this reproductive stuff, give me until the end of today to like make this into one PowerPoint of the key points, because a lot of it we don't need. Some of it is maternity. I don't want to get into maternity yet today. So I'm going to take the maternity stuff out of this. So don't run and print this whole thing out and think it's all in the test. Let me fix it. Let me just go over the key points that you need to know. The reproductive chapters that are in here for me are 54 through 58. I would read through them. One of them talks about BPH. There's some screening recommendations. There's some different medications that are for the prostate patient or the male patient. Understand those meds. We're going to talk a little bit about menstrual disorders. And again, it's going to be very quick. There's not a lot of stuff on NCLEX related to reproductive. So we don't spend days and days. It's just more like a subtopic. Last year, I think we had this one PowerPoint and that's it, and one summary packet. So I'm trying to find that packet. After we finish reproductive today, if there's anything else that we need that I see today that needs to go on this PowerPoint, we can go over it tomorrow. There's a short summative packet, and then that's it for reproductive and Reno. And that's what's on the exam next Monday. So as soon as we finish this, these are 2 practice tests for renal. We're going to do the first one. I'm just going to have you guys copy it and do it in here. Let's see what we know so far. And then the second one, you guys can work on this afternoon or tomorrow or whatever. Okay. And then we can do like we did the last time. We can do some Jeopardy questions, you know, whatever you need to do to try to help us get ready for the renal test next week. And from there, we're going to move into musculoskeletal. That's what comes next in our book. Then skin, and then endocrine, and then we're almost done our med-surg book, which is pretty exciting. And then there's a last chapter about immune disorders like lupus and rheumatoid arthritis and cancer. And we'll be finished. Not the year, we just finished this book. And then we're moving on to maternity and peds. We get stuff to do mental health. We still have some pharmacology that we have to do. But pharmacology is hard to do as we move through the year. Hopefully you've heard meds, and then we'll come back and do pharmacology again. And then it'll be, oh yeah, I've heard that med, what's it for? Oh yeah, I think I've heard that before. What do we use that for? If I started in the beginning of the year and just said, hey, know all these meds, it would be like crazy. So we have to learn how to apply that. So reproductive system. Male and female, obviously, we're talking about. What does menarche mean? That's the first period, first menstrual cycle. Okay, remember, I keep telling you, don't study statistics like it's 12.4 years. You know, obviously, we all recognize that typically around 12 to 13 years of age is the average age. Again, it can occur from anywhere 9 to 17 years old. Ovulation occurs, your menstrual cycle is typically about 25 days. Ovulation occurs about 14 days. Again, this is basic stuff. It's just general introduction. But you need to recognize what menarche even means. If somebody has menorrhea is bleeding when you have a female has her period. If somebody has amenorrhea, what does that mean? They're no longer bleeding, it's absent. Who could have amenorrhea? What if you were pregnant? Do you have a period? No. What if you went through menopause? Typically, the time period of menopause, again, is anywhere from 45 to 52 years of age. How do we know that you're completely through menopause? You have not had a period for 12 months. That's basically how we know that you've completed your menopausal time. Again, menstruation continues until menopause. What now has happened to the patient that's postmenopausal? Where does their estrogen level go? Up or down? Down. Goes down. So now that their estrogen level goes down, what are they at risk for? Bone fractures, Estrogen is needed to keep our bones strong. It's recommended that people take estrogen supplements after menopause for these reasons. What else would you tell your female patient postmenopausal? Drink more dairy, vitamin D, right? Supplements for that to keep your bones strong. Wouldn't it be important for that person to exercise? Yes, in order to keep their bones strong. So we have to recognize what happens after menopause, what are some of the risks for that female patient. And again, men don't go through menopause, even though midlife crisis happens for a lot of men. But mostly, obviously, it's women that go through menopause. So here's just some terms. Dysmenorrhea. Well, dysmenorrhea means painful urination. What do you think dysmenorrhea means? Painful menstruation. Some people have more pain than others, right? Some people, lots and lots of cramps. What other symptoms do female patients get when they are getting ready to have a period? Bloating, mood changes. What'd you say? I can't hear you. Cramping, nauseous. Everybody's a little different. So you just need to recognize these terms again. What does amenorrhea mean? Absence of menses. That's having your period. Bleeding. What's premenstrual syndrome? Again, PMS. You know, it's a real thing. It's not in your head. It's caused by an imbalance of estrogen or progesterone. And this is prior to starting your period. So it's not that you're just moody. It actually is a hormonal imbalance at that particular time of the month prior to starting your period. Endometriosis. What is that? Have you guys heard that term before? What is it? Anybody realize what it is? Endometrial tissue is normally inside of your uterus. Where has that now implanted or grown into? Your fallopian tubes, into the ovaries. So that endometrial tissue is normally found in your uterus. That is the tissue that allows for fertilization to occur. That's the tissue inside your uterus that grows and develops and supplements a baby or a fetus. What is endometriosis? That tissue has grown into or spread into abnormally into the fallopian tube, the ovaries, into the pelvis. Endometriosis, if it's severe enough, can lead to infertility. So it can make the patient infertile. So while it can be a very stressful, significant problem. How do people get ectopic pregnancies? Have you ever heard that before? What's that mean? You're pregnant, but where did it implant?
In the fallopian tube.
Where should it implant? Inside the uterus. So people that have endometriosis as a baseline are more likely to have an ectopic pregnancy. Makes sense, right?
Miss Anderson.
Yep.
I have a friend that has it, and more so in her earlier 20s. I think she had like 2 miscarriages, and even through high school, like her pain would be unbearable. But thankfully, I think she's had her 4th child now.
Yeah.
So,
which is a big deal for that person. We take it for granted that people can get pregnant and it happens and it fertilizes in the wrong place, and it doesn't always happen that way. So people with endometriosis, I have a friend that had it severe enough, had 2 miscarriages, just like you're saying, and then became infertile and not able to have children from endometriosis. My daughter-in-law, a couple years ago, had an ectopic pregnancy, very severe. Her tube ruptured. She ended up with surgery, ended up very sick and septic, ended up on a ventilator, all from trying to have a baby. Now, they're the ones who just had the baby in November. So they went through 3 years of all that stuff because she has endometriosis. So again, you take for granted that everybody out there can get pregnant, and it seems like the people that shouldn't get pregnant can get pregnant the easiest, right? And then the other people who are trying, this is sometimes one of the reasons why they can't get pregnant, because they have this history of endometriosis. So these are just terms that we use for female menstrual problems. What's menopause? Area where there's permanent cessation, stopping, and you no longer have your period, or menses. That's the name for it. So here's our symptoms now for menopause. Mood changes, decreased REM sleep. So people in menopause have trouble sleeping and staying asleep. So that affects their mood changes even more than they already have because of hormonal imbalances. Problems with decreased skin elasticity, so drier skin, drier decreased vaginal secretions, night sweats, hot flashes. We all heard these things, but these are actually symptoms of being in menopause. And again, it's can be treated, and some of these symptoms can be minimized by taking HRT, that's hormone replacement therapy, and that means taking estrogen or some kind of hormonal treatment when you're postmenopausal to try to decrease these symptoms. Now, if somebody has a total hysterectomy, what happens, how does menopause come into play? If they have a total hysterectomy, both the ovaries are taken out and the uterus is taken out.
It's faster.
What happens? They're put right into menopause. Why? Because they don't have ovaries anymore. They don't have a period anymore. So people that might have uterine cancer at age 35, it's not time for menopause yet, but they have to have everything taken out. So again, you might have patients that have surgery. If they have a salpingo-oophorectomy bilateral, what does that mean? It's a long word. That means they have both tubes taken out and both ovaries taken out. Oophorectomy means ovaries. Ectomy means removal, right? Salpingo is the tubes. So could someone like my daughter-in-law who had an ectopic pregnancy on the left side, okay? She had to have her ovary and tube removed on that side. Did they tell her she had a chance of never having children? Yes. So how do you think she had the baby that we have now on the right side? Right? I mean, so people can still overcome these issues, but sometimes people can, sometimes they can't. Menopause, what happens? No longer have menses. Here's our signs and symptoms. What's recommended for them? Hormonal replacement therapy is called HRT. There's different types, estrogen patches, estrogen tablets. Again, you have to look at the risk and benefits. Some of the things that are a risk for HRT, more likely to develop blood clots. So that person's higher risk for DVTs or PEs. Doesn't mean they're going to have it, but it just means that you have to be more aware of it. It's a higher risk for that person. Higher risk for breast and ovarian cancer. Yes, you're treating these symptoms and you're trying to maintain the balance. So the lowest level of hormone replacement therapy that can control your symptoms is what we want you to be on. You don't just give everybody high doses of estrogen and hope that they never develop one of these other types of cancer. So you have to be careful. And again, it's your gynecologist or their doctor that's ordering these hormonal replacement therapy. It's a prescription, typically. Now, are there over-the-counter medications that treat menopausal symptoms? Yes, there are. But if somebody has ordered HRT, that means that they're getting a prescription hormone replacement therapy because they have went into menopause. So we're trying to treat those symptoms. Increase your risk of DVT and MI, especially in the first year. So again, you're outweighing the risks and the benefits of hormone medications. Male reproductive system, obviously, here's the parts of it. No female patient has a scrotum. I think we all figured that out by now. No female patient has, yes, we have a sex glands, but they're different, obviously, than the male patient. We already talked about a PSA level. One other level, okay, first off, PSA, where do we want that to be? Less than 4. Less than 4. So there's your magic number. Somebody that has a PSA level above 4 is typically higher risk, means that we're looking at that level and we're saying, hey, they need further evaluation. One thing about the digital rectal exam, this is a key point, and I don't even know if it's on this slide. If a doctor is going to do a digital rectal exam, they do, and this might, I think this is a question that's going to come up in the TI. They do the PSA level before they do the exam, before they physically do the exam. Doing the exam, remember what we said it is, it's physician through the rectum feeling the prostate to see if it's enlarged. When they do that, they can make the PSA level go up abnormally a little bit anyway. Does that make sense? Like, because of the stimulation from the exam. So here's your sequence. We're going to get the PSA level first, and then we'll do the rectal exam. Okay, so now they got the PSA level, and it's 2.0. Is that okay? Yes. That's fine. That means the patient doesn't have a high PSA, they probably don't have prostate cancer, but they could have an enlarged prostate. So we do a digital rectal exam and the doctor feels like they can palpate the prostate. What do you think the next step is? It's ultrasound of the prostate, right? This is kind of the sequence of how they figure out what's happening with the prostate. There's another medication, or another lab, sorry. It's called an EPCA. It's right in your book, in your reproductive chapter. What is that? That is the most specific level now, and it's just developed in like the last 4, maybe 10 years. It used to only just be PSA that we did. This level is most specific to the prostate. So look, a value greater than 30 suggests prostate cancer. Does it fully diagnose prostate cancer? No. How do we diagnose it? Now we do a biopsy. Is this making sense? We can't just say, okay, you have a high PSA, you have cancer. What we can say is that the PSA level is high and your EPCA level is high, it's above 30. We better do a biopsy of your prostate to figure out, is it just benign or is it cancerous? Everybody understand how we figure out? And what if it's sometimes they do. I've heard of them using this. Now, there are some surgeons who will still say, hey, we want to do that biopsy. This could be your one test, and again, I'm just trying to help us recognize it. If we see this in a lab, less than 30, like if we see this on a test question. And if it's high, what does it mean? Pretty darn likely that they have prostate cancer, right? In a nutshell, that's basically what I'm trying to say here. We don't need to get really like hours and hours of studying the reproductive system, but these are the key things that we have to recognize that are going to be levels that we might see. So EPCA, yes, if you diagnose prostate cancer, do they still sometimes feel biopsy? Yes, they do. But that level above 30 tells us that it's pretty likely that it's cancer that you have. Now, there's that digital rectal exam. What are we looking for? It's the physician doing this, not us. The nurses don't do it. The physician does it, and what are they looking for? An enlarged prostate. Can they feel and palpate that prostate? And now we move on to ultrasound or other tests to be done. The key thing about that, I'm going to get these levels, this lab stuff, before the exam, okay? Prior to the exam, bottom line. Okay, so we've already talked about BPH. Here's our risk factors. We're not going to go back to it again, but again, your diet can be a risk factor. Again, we don't always know why somebody develops an enlarged prostate, but here's some things that we recognize can contribute to it. Diabetes, family history of having an enlarged prostate, an older male, again, every 10 years, that percentage goes up by 10% more likely to have it. High fat, high protein diet, African American race, higher incidence of having issues with BPH. Those are symptoms. We already talked about it. If it persists, here's the key point about it: frequent UTIs and kidney damage on the person. So it has to be treated. There's another medication. We talked about tamsulosin that helps increase the flow. There's another medication called finasteride. FINASTERIDE. I'm just trying to help us recognize some of the nodes we might see related to the male reproductive system. Finasteride. What does that do? It decreases the swelling of the prostate. So it hopefully helps with the symptoms that the patient has, the male patient has, which are dribbling, hesitancy, unable to empty their bladder. So it's called finasteride. Here's the key point about this medication. Write this down, because if you see this on NCLEX, you're going to remember it. It is what's called teratogenic. What the heck does that mean? It means that if a pregnant person comes in contact with it, it can actually cause damage to the baby. So, if you're the nurse and you're pregnant, if somebody's on that medication, should you be handling it? No. If this issue for a patient is happening and the patient's 30, let's say their wife or female or significant other, whatever it happens to be, is 30 and they're a childbearing age, should they be in contact with that medication? No. Should they be, they have to be very careful that they even touch the urine of the patient that's taking it. That's how much it can affect the baby. So finasteride is a very teratogenic is the word that we use. It can harm a fetus. So it's just something to write down, put in the back of your head. We got to be careful when we put the male patient on it. Again, are you around anyone that is pregnant, or is your significant other of childbearing? Could they be possibly pregnant? And we better think about this medication. It talks about it in your med-surg book. Here's BPH meds. There's another one. Yep, finasteride increases the size of the prostate. One thing about BPH meds like Flomax and finasteride, Flomax, the other name is tamsulosin. One thing about these meds, look, it can take up to 6 months to a year for them to work. So the person that has BPH and is having trouble peeing and is taking these meds, tell them you're not going to notice the effects of this right away. It's going to take a little bit of time for these meds to kick in, and it could be months before you really start seeing the results of this. It's important because if you're a male and you're having these symptoms and you, okay, here's your medication we're giving you, aren't you going to expect that after a couple days it's going to be better? You're going to think, okay, well, I'm on meds now. It doesn't happen. It takes 6 months up to a year. Impotence and decreased libido are possible side effects. So what do you think happens to the male that has those side effects? What's he going to do with the meds? Stop taking them, right? So you have to remember, I need to tell you these things. These are expected side effects. You need to let your doctor know if these side effects are happening and they're preventing you from wanting to take this medication, right? Because these are things that you're going to expect could possibly happen. Again, there's the alpha blocking agent. All that is called tamsulosin. What's it do? It relaxes the smooth muscle of the bladder and relaxes the size of the prostate. Here is a side effect, put a little star next to this because I've seen ATI questions about tamsulosin. And this is important in real life for us when we take care of people. Who are we taking care of in long-term care? Isn't it older people most of the time? Isn't it older men with prostate problems? Because remember, every 10 years, your incidence increases by 10%. So you're going to be given tamsulosin to people. That's a fact. What do we need to know about it? It causes orthostatic hypotension. Do we know what that is? Yes, you should by now, right? It's a side effect. This is a key point. This could be your NCLEX question that the patient was recently started on tamsulosin for BPH. What are we going to do for this patient? Because in the back of our head, we're going to remember orthostatic hypotension is a side effect. We're going to tell them to get up slowly and monitor the blood pressure. Does that make sense? This is a med you're going to be given. It's not like Utopia World. This is everyday real. Tamsulosin, the other name is Flomax. It relaxes smooth muscle. It's used for the people that have BPH, and we tell patients to get up slowly when they're on this med because the patient doesn't realize this is what's happening to them. When they go to get up, they feel dizzy, they feel weak, they feel like they might pass out. Because they started on this med a month ago, it's starting to kick in now, and now my blood pressure is orthostatic, meaning that I'm going to tell them get up slowly. What else would we tell them that would help with the blood pressure dropping like that? Get up slowly, and then what about drinking? More fluids or less fluids? More fluids, right? Everybody with me? This is what we're going to pick. This is real life, what we're going to do for these people. The other med that we just talked about, oxybutynin, remember we said it's for bladder spasms? Just be careful with that med. That may not be your best solution. Sometimes it's used for bladder spasms, but it's an anticholinergic. So what do people that are on anticholinergics, what can they not do? Said it 4 times. Over 4 things, many times. They have trouble seeing. They have trouble with spit. They have dry mouth. Don't they have urinary retention? So while we sometimes use it for bladder spasms, is it the best thing for somebody with BPH? Not always. Does that make sense? Because then we make their urinary retention worse. So be careful using that med. You might, oxybutynin, you might see an order for it for bladder spasms in the patient that has bladder cancer. But remember, if they have prostate problems, sometimes it works, but we got to be very careful because if it makes your urinary retention worse, isn't that going to create a UTI for that person? So we use finasteride, listed here, the increases the size of the prostate. Remember, it takes 6 months to a year to work. Impotence and decreased libido are side effects. Okay, now there's an alpha agent. And again, you may not recognize what category it goes in, but what we do need to know is tamsulosin, that's what we're gonna see. It decreases the prostate gland, relaxes smooth muscle, that's how it helps you pee better. And again, what it says, hypertension. They're the questions you're gonna see related to these meds that will come up every time you're on NCLEX. We already talked about what a TERP is. There's some of our, again, you see what I mean about how this PowerPoint kind of repeats the other ones. I'm gonna try to combine them so we're not saying the same thing over and over again. Here's key points when the person had a TERP or BPH. Drink more fluids. Again, no lifting, no strenuous exercise, no sexual intercourse for 2 to 6 weeks, depending on how long the doctor tells you. Every doctor